Great, so we'll kick off. Welcome everybody. My name's David Reid. I'm the Director of Trauma at the Royal Melbourne Hospital. I'm a trauma and colorectal surgeon and I'll be chairing this evening's Victorian Trauma Grand Round, which will be focusing on elderly trauma. Now, I'd like to start off by acknowledging that we're meeting on the traditional lands of the Wurundjeri people of the Kulin Nation, and pay respects to elders past, present and emerging. And I'd also like to point out we do have registrations not only from the land of Wurundjeri, but also from places that we beat frequently at cricket, such as Ireland, UK and New Zealand, and other nations such as Greece, Singapore, Saudi Arabia, Fiji and the Netherlands. So welcome to those people on the other side of the globe. So just to let you know, this will be recorded, which will be good because you can watch it at a later stage, anything you want to go over again. And recommend it to friends and colleagues who might be working at the moment, but just to let you know, any questions, etc. that you ask may be recorded. Talking of questions, if you would like to take a photo of this now, so this is the Slido app, which will be accessible by this QR code, is a preferred mechanism to receive a question, and you can type that in anonymously. And as your questions pop up, you just put them in, and we will collate them at the end, where our expert panel will smash through them nonchalantly, I am sure. So we've got a great program together with talks from trauma surgeons, emergency physicians, trauma geriatricians and allied health and nurses. But to start off, I'll just introduce what we've been talking about, and that is the challenge. Don't want to call it a problem, but the challenge of trauma in the elderly. And central to this is the definition of what is elderly, which can vary quite a bit. And we all know that there are some 65-year-olds who are doing very well and others not so well, and same with 90-year-olds. So it's not just a biologic age, but a physiological age and their activity. But the agreed age of 65 years is now 9 years and 3 weeks away for me. So I have a vested interest in making sure this service is up and running really well for the next decade. And we know our elderly trauma patients, in some ways like our paediatric trauma patients, are a vulnerable population, more likely to have major trauma and have special needs and interests. And I say just as the same as we tailor our system and have to our paediatric trauma patients, we need to tailor our system to the needs of our elderly trauma patients. And you've all heard that it's going to be a growing problem as a higher proportion of our population is over the age of 65 as time goes on. Even at this point in time, it's roughly a third of our trauma patients admitted at the Melbourne, and it's similar to other sites, are elderly as defined by the age of over 65. The trauma patients and the elderly trauma patients are a little different, not only in their physiology, etc., but a little bit in their epidemiology. Trauma, as we all know, is a disease of particularly younger men, but as age advances, that gender disparity disappears, and to the extent that in the older age group, then females are the predominantly injured in this cohort. So even more important for elderly women. We know that the elderly people don't trigger off our trauma team activations as well as the younger people. So of our major trauma patients, about 80% of our younger patients will trigger correctly a trauma team activation, but that's down to about 60% of our elderly patients, and that's a lot to do with physiological and mechanistic sort of problems. And when we look at those that don't trigger a trauma team activation, there's plenty of them that just don't trigger it, despite. And I think there's scope for us to give consideration to revising them. But even those that probably in retrospect should have triggered a trauma team activation, a lot of the injuries are occult or emerging, such as the classic and the major one is blunt chest injury. No surprise, the mechanisms are different. For the younger population, the predominance of motor vehicle crashes, but once you're over 65, is low falls predominate, and it has the highest mortality or case fatality rate of any mechanism of injury. Plus, there's the bugbear of frailty, which of course increases as you get older, which we're starting to realise is just as important as the severity of injury, if not more important. And all of this adds up to a higher mortality with every age group, as this is the STR annual report data from not too long ago. And in that higher age group of around about 85 above, 30% of the major trauma patients won't leave hospital alive. So it's a very mortal disease, trauma of the elderly. So without further ado, I will get into our program, and I'll invite up first Dr. Kate Martin. She's a general and trauma surgeon here at the Royal Melbourne Hospital and the Deputy Director. She's extensive experience in trauma care both here and has worked at the Alfred and works at the Austin, and a special interest in trauma resuscitation, abdominal, pelvic and chest injuries, and she'll be presenting a case for us.
Thank you, David, and welcome everyone. Thank you for giving up some time tonight, and I'm not that far behind David, so I think we've all got a vested interest in making sure we get this right. I'm going to present a relatively typical case, and this case is pretty much presented as is. We haven't changed anything with this case. And really, just to set the scene, 73-year-old man, we'll call him Reg. He's fallen from a ladder, because we know what we say about anybody older getting up ladders. They never listen to us. And he's actually landed on the concrete, hitting his head. Attended to by his wife immediately, who heard the thud. Injuries that were pretty evident at the scene were a chest wall and shoulder pain on the right-hand side, and evidence of right-sided head strike as well. He did seem a little bit vague, a bit confused, but there wasn't actually a witness loss of consciousness, and he did have a wound on his right elbow that appeared to be bleeding. He was a little bit hypoxic, but that improved with some oxygen once the ambulance arrived, AV, and then they also treated him with a soft collar, some antiemetic, some analgesic, and some direct pressure to that right elbow. Primary survey on arrival is that you can see here. His scalp was looked at early. There was no active bleeding, so it didn't need any attention at that stage. He's maintaining his airway, soft collar in situ. Saturations had improved a little bit more at this point in time, and had reasonable air entry that was equal bilaterally. His heart rate was fine, his systolic pressure was fine, his EFAST was negative, and his tummy was not of concern. And he was a GCS of 14 to 15, just depending on what his eyes were doing. And he wasn't too cold yet. So, secondary survey, and I have put a bit of time into going through this because I think this is important, and it's important for all our trauma patients, but I think in particular for the elderly trauma patient. We start obviously with his ample history there, and I think the most the points I want to highlight here is that he has atrial fibrillation and he has hypercholesterolemia, and his medications include rivaroxaban. I mean, they're all on some anticoagulant, as we know. Particularly of note is that he is at home with his wife, independent, retired labourer, and he does like a glass or two, maybe 3 of wine at night, and he has a clinical frailty score that's calculated on admission as well, which is a standard of care here at RMH, and he scores a 3 there. So again, this is really just that same information. As you can see there, laceration without active bleeding on his scalp, bit of right-sided chest wall tenderness, no abrasions on the chest itself, but good air entry. And he had some bruising in his right upper limb, and he had the laceration, which was no longer bleeding from his elbow. So a pretty standard plan of care just initially after the end of the secondary survey. Analgesia, his bloods, his ECG. He did get some staples to that scalp, and appropriate imaging was organised, and it was evident that he would need to have an abbreviated Westmead PTA score or AWOPTIS. And obviously we're going to withhold the rivaroxaban. So sorry that this CT brain's going through a bit quickly here. You don't need to try to read it. Other than to say CT scanning, yes, he did have evidence of traumatic brain injury, but it was subtle. So he had a little trace of subarachnoid blood, some small bilateral subdurals, and some intraparenchymal hemorrhages that were small. His chest, however, and this is, as you know, really the focus of a lot of our patients, did show some, and can I just have that looped, please, that CT scan or that video? Right rib fractures, quite extensive down that right-hand side with flail segment as well, from 3 to 7. Associated pulmonary contusions, and we do use the stumble score here at RMH2 just to get an idea of the severity of those fractures. And you can see here his stumble score was calculated with the points that you see there in red, and we know with our patients that a stumble score of greater than 31, obviously they come in under trauma, but we also activate our APS and our ICU admissions because of the high incidence of the need for intervention. And then right upper limb, he had those injuries, as you could see there. So management that was initiated on admission, as you can see here, just the general goals of care A were discussed and decided upon. APS were involved early before he left the emergency department. Obviously, we get the neurosurgeons involved as well, and they were pretty keen to have him in their HDU. And also an ICU review, although they felt he would be fine in the high dependency unit of neurosurgery. And I would like to put a plug out for maybe a new primary survey in our older folk, A, B, C, D, E, F for frailty and G for goals of care, particularly in our older folks. So, and I think that one's my last slide, and we're now going to move on to, that's the start of the case. We'll now move on to some of the discussions that will follow. I'll come back to you later.
Thanks, Kate. So I'll invite next Dr. Maya Cubitt to the podium. Maya's a emergency physician and a hospital and home physician here at the Royal Melbourne. She's a Masters of Traumatology from Queen Mary University in London and an appointment at the University of Melbourne Department of Critical Care with research interests in acute care of older patients. She's going to be speaking to us about trauma triage in the elderly.
Okay, I'm on a tight time frame, so just watching Kate down here, who's got the minutes. She's keeping me in line. So whenever I talk about injury in older patients, I always start with my Nana Shirley. She's sitting here beside my daughter Lily, because this photo reminds me that injury in older people is about all of us and our journeys. I was once Lily's age, and faster than I care to imagine, although not as fast as David, I will soon be Shirley's. So I want us all, just for a minute, to take a moment and close our eyes. And I want you to imagine your grandmother, your grandfather, any wise elder that's important to you. And now I want you to imagine them sitting next to the person besides you, loved one. And now I want you to imagine them sitting beside everybody else in the room. And now I want you to imagine they're sitting beside our case. And every single one of those people is acutely ill or injured. And your job is to be the triage clinician, to decide who should and who can't wait. How does it feel? If you're considering it properly, it should feel a little overwhelming. Now open your eyes. And let's continue tonight's conversation focusing on the older injured patient in that crowd and their journeys. And this really messy beginning, triage. Triage is an expert role. It aims to balance clinical justice so that patients receive the level of care appropriate to their clinical need, efficiency, and the most useful application of our finite resources. It needs to follow some key principles of speed, thoroughness, and reproducibility, but it should not aim to diagnose. It's a dynamic process repeated at many stages in a patient's journey. And we have to accept an uncomfortable truth. It will fail someone. Therefore, for it to be successful, it must lead to something better, an individualised assessment and better diagnostic accuracy. And there's a man up the back who was promising me he would scroll, but he's not doing that, so that's okay. There he goes. Mark Butler, in the latest edition of the Emergency Triage Education Kit, called triage an enormous responsibility. So let's all take a moment to give some gratitude to the triage clinicians in our audience, vital members of our trauma teams. And these are ours.
Hi, I'm Rachel. I'm one of the clinical nurse specialists here at the Royal Melbourne Hospital Emergency. So the triage process starts here, where you come to the clerical staff and register your details on the system. Then you come down to me, the triage nurse, where you have your assessment, tell your problem and have your vital signs and assessment done.
I always try and welcome people to the department just so that they feel like they're seen and they're heard. But it can be hard when we can't meet people's expectations of what they want to get from their care. What makes me proud to be a triage nurse is that I am the first point of contact for someone that's having a really bad day. And I get to welcome them to the hospital and provide reassurance that they're going to be okay.
I think older injured patients are difficult to triage because they often come in by themselves. They don't always understand the questions that you're asking at triage. Sometimes it's difficult to get a proper history on why they're presenting and what led to them presenting. It's my favourite role in the emergency department because I think the face that you show at the start of the person's experience in emergency and the communication that you give sets the tone for the experience that people can have in the emergency department.
So in that video was Rachel Keys, one of our senior emergency nurses here at the Royal Melbourne. Rachel and I have tried to convey the complexity of triage for injured older people in this paper, and we wanted to try and get everyone on that same page tonight. Along an injured patient's journey, there are many people performing triage. Or said another way, there's many of us that are given an opportunity to assess a patient's needs, define their urgency, and advocate for them. And all of us coming after a clinician earlier in a dynamic patient journey needs to take a moment to check our judgment. Research tells us that even experienced trauma clinicians with time for good clinical examination in an all ages group are only moderately good at identifying life or limb-threatening injury. Our level of accuracy is worse for torso versus peripheral limb injury, and missed injuries increase with polytrauma and any signs of shock. Diagnostic uncertainty and resolving that using rapid access to objective tools like bedside ultrasound or CT scanners is much more necessary than many of us would care to admit. It's also the point of triage, right? To try and establish who should be prioritised for that early access to those next steps. And in most triage processes, the case that was presented tonight is not hard. He's very clearly going to get a trauma alert at the Royal Melbourne Hospital. He's a high fall, he's hypoxic, he's had blunt chest injury, and he's got an altered conscious state. But the authors in that paper also astutely point out that any clinician making a decision, in gathering enough information to inform that decision and who gets priority, is impacted by stress, fatigue, time pressure, and lots of other human factors, all of which are nicely concentrated in a crowded triage space. And for older patients, that's often confounded by low force mechanisms, ageism, languages other than English, cognitive impairment, physical vulnerability, and much more difficult clinical assessment, which leads to under-triage. And on the flip side, as we age and we get closer to our final years of life, we have an increased risk of overdiagnosis and low-value futile care. This is really complex decision-making, and it's happening in a bottlenecked, overcrowded acute care system. The decision support tools that we use to help us with this cognitive burden are increasing. In Australia and New Zealand, we use the Australasian Triage Scale, and in its highest categories, it's good at identifying those people who need hospitalisation or ICU admission, but the proportion of hospital and ICU admissions within each category is highly variable. Now, I've got 15, you're out of time. I've been going for 7. Kate, you're being so overzealous. So there's significant variability in the assigned level of urgency that you get depending on the type of service you present to, the age of your triage nurse, and the type of presentation that you have. And we know that the older the patient is, the less likely they are to be assigned an urgent category. And in our modern triage systems, everybody's specialty matters. So we're overlaying more and more problem-based triage support tools, which, contrary to triage categories that were designed to diagnose urgency, aim to suggest a primary diagnosis and elevate that patient to a much more urgent pathway of care. And for trauma, as David has said, we know that older patients are less likely to meet those definitions. And in pre-hospital triage, there's huge variability in sensitivity and specificity for identifying major trauma in older patients. As expert trauma clinicians, we all know that low falls from standing height are the most common cause of injury-related hospitalisation and injury-related death. And we all know that older patients carry that burden of injury. But our trauma system was not designed with that paradigm in mind. Everything that we do is designed to identify the focus of the bleeding and access definitive surgical care. But we're not sure if that's relevant to injured older patients. We're not sure which older patient it's relevant to, and we're not sure whether it achieves outcomes that matter to them. In Australia and New Zealand, we're not actually sure who's caring for injured older patients. Emergency physicians remain quite confused about the next best destination of care because there's no evidence to define that for us. From this survey, the most common destination for injured older people is a general medical ward, and generalist physicians are the most common provider. And this research didn't reach community providers like GPs or residential aged care facilities. So the trauma team that we need to seek to activate and educate in injury prevention and injury management for older patients includes many more clinicians that are in the common audience of a Victorian Trauma Grand Rounds. This is old data now from our trauma service, but it says that we admit about 7 patients a day that meet state trauma definition, and with our 2-tiered response of a call or an alert, we activate those in about 85%, which means that about 40% of our trauma team activations are for major trauma. But in patients later confirmed to have major trauma, we know that older women with low fall mechanism are much less likely to have a trauma team activation, which is unfortunately consistent with our gendered barriers to accessing care in almost every disease state. It leads to an increased ED length of stay, an increased time to definitive imaging, and an increased time to definitive surgical care when that's required. If we go back a bit further in the journey to the triage role from an ED perspective, we're seeing about 250 patients a day here, and there's a roughly even spread of about a third admitted, a third discharged, and a third go through our ED short stay, about 70 patients a day. We see about 9 low falls patients a day, although that's probably an underestimate because we use a triage code that the triage nurses get choice in, so it's probably underestimating the number. And we admit about half of those to short stay and half of those to a ward. So it's very complex. What should we do with all of that information? My key takeaways for injured older patients are that our success in injury triage relies not only on triage, but what becomes before it and what comes after. Our clinical examination is an important tool at reducing our risk of missed injury, but only if we apply it carefully, systematically, and repeatedly, and we need to accept that it will fail people. Early objective adjuncts like bedside ultrasound and CT scans are our friends, especially when we are struggling with clinical assessment in more complex older patients. And system-level decision support tools need to be relevant to the patient in front of you. So where to from here? We need to improve triage at more points along a patient journey to better define who needs to be where, why, and when, and make that easier to achieve for older patients with low fall mechanisms. And most importantly, we need to be honest with ourselves and honest with our public that in order to protect the resources for those that can't wait, We need our triage systems to allow us to define a group of people who can wait, where they can wait, and what they're waiting for. Not everybody can be urgent. Somebody has to wait. And I want to take a moment now just to briefly acknowledge emergency physician Professor Glenn Arentz. He saw the future of injury triage long before any of us, and in 2017 introduced a triage-focused pathway of care for low falls. It's just surpassed its 10,000th patient. By identifying falls at triage, he, wherever that occurs, he uses evidence-based tools to make an impact and optimise outcomes that matter to older injured patients. If we better define where is the right place for which patient at what time frame in their journey, we can together seek and treat the reason for the fall, the injuries suffered in the fall, and opportunities to prevent future falls, and care in line with what matters to our older patients. We already have the tools that we need to steer our trauma systems towards our loved ones, our older patients, right from triage. Thank you.
Thanks, Maya. It's a great talk, and now I'm really hungry for ice cream. Next up, we've got Dr. Kate Gregorovich, who's a geriatrician at the Royal Melbourne Hospital. She works not only in trauma, but also acute care, general medicine, and subacute at home. She has an appointment at Safer Care Victoria, where she's involved in multiple projects in quality and safety and improvement, and she's going to be talking about low falls and frailty.
So a couple of weeks ago, I was at a children's party at a park, which is where I spend a lot of my afternoons. It was a lovely sunny day, and I looked across and saw an elderly gentleman on the footpath lying with his four-wheel frame just ahead of him. I went over, people around him were, very capably providing first aid, so I went back and they told me that an ambulance had been called and was on the way. So I went back to the party. Then out of the corner of my eye, I saw them trying to move him. Now this is a bit concerning because he had looked like he had a shortened externally rotated leg. And he was calling out in pain. And I went over and had a bit of a better look at him, and he was drowsy and confused. He had chest pain and this leg. And there was by then it was apparently come from a nearby aged care facility. Some of the nurses from the facility had come there. And what they'd understood, they'd been told, was that an ambulance wasn't coming for him because he was a low fall, and they should try and get him into a wheelchair and take him back to the facility. So I asked them to call the ambulance line back, and understanding it, I know that our ambulance colleagues are under a huge amount of pressure, but essentially until I said, I'm a doctor, you need to get an ambulance, they weren't going to send an urgent ambulance. And, this was a really good lesson for me because I see these people, so this guy had, 3 suspected injuries. And I see people after my ED colleagues have, assessed, diagnosed, given pain relief. So it was just a really good thing for me to see this person who had, this common mechanism of injury that I see, but how hard it was for people to get care because of this perception around low falls. And, as David showed in the earlier slides, low falls are the most common cause of injury in this group, and they also contribute the most deaths in the older age group, more than car crashes. But somehow there's this sort of perception that it's a lower risk mechanism of injury. And so going through some of the things that Maya said as well around the models of care for older adults, and I think these is, because obviously, people like this have got other problems as well. These are 3 sort of important papers that have been published recently. And so one of the models of care that's developed a lot over the last few years has been the Trauma Older People Service. And that's shared care between geriatricians and trauma services. And I know there's a lot of centres coming around Australia doing this. The Royal Melbourne, I believe, were first. And there is some emerging evidence that this does decrease mortality. The other things as well is that we still have a lot to go in terms of working out the models of care. And so for low energy mechanism of injury, the evidence isn't clear whether people do benefit from a major trauma service. It's not that they don't, it's just that there's not enough research to show because the trauma system is so set up around younger people who do benefit from it. But I think it's still really a question coming up. And just as well, this increasing knowledge, which I think is becoming really accepted now, that frailty is so important in the assessment. And so as part of our trauma service, we started a database. One of the challenges, again, in older trauma is that only the majors tend to get coded, but for older adults, you know, something that would be considered a minor trauma can still be life-threatening. So we have a database, which we're lucky enough to have a research assistant. So for 1 year, we've got a really great data set. And we looked at some of these different characteristics. Another challenge, and this is a worldwide challenge, is for this group with injuries and frailty and medical comorbidity where they should go. And there is sometimes a bit of clinician judgment that falls into it. And again, this is a problem worldwide. And I was in the UK on sabbatical recently, and even in their trauma units, they would still have some people with some pretty significant injuries being cared under medical units. So again, in the research space, it also causes another problem because a lot of the times only the patients admitted to trauma end up being in the research data sets. So one of the advantages we had at Royal Melbourne is we were actually able to compare anyone who came in with trauma and which unit they went into. And again, the orthogeriatric group often get excluded because they have such a well-established model of care, but really there's a lot of crossover between someone who comes in from a nursing home with a NOF and someone who comes in with a couple of fractured ribs. And so looking at this, unsurprisingly, the patients who were admitted to medicine were a bit older than the ones who went to trauma. They were much, much more likely to have come in with a low fall. They still had a median injury severity score of 9, so getting some reasonable injuries coming through compared to a median injury severity score of 14 for trauma. And they're across all of the groups, whether it was trauma, orthopaedics or general medicine, the mortality was the same. This is just univariate analysis. But I think that's significant because even though the injuries were different, you were still getting this quite a decent mortality risk across all groups. And so this is just showing some of the gender differences in trauma as well. And so overall, men, this kind of goes for everything in older age, men are more likely to die from their with a similar injury severity score compared to women, although you start to lose the trend a little bit in the higher levels. And so this is, when we look at their multivariate analysis of mortality, so age, unsurprisingly, is significant, male sex, injury severity score, performing as we'd expect, the Charleston comorbidity, and also the low falls. People at a low fall, when you account for all of these factors, age, male sex, ISS, CTI, were around twice as likely to die. And again, this I think comes back into this thing of this idea of low falls being a low risk mechanism of injury, because I think if you are in hospital with your injuries from a low fall, you're a bit of a self-selected group. And one thing we couldn't include in this model was frailty, because at this time, only the trauma registrars were actually collecting frailty, but I'm hoping that'll start happening for the medical registrars. Because again, I think it's so important to get a sense of someone's underlying physiological reserve, because that tells you so much about their capacity to recover from some kind of physiological stress, like a fall. The other thing which we've identified is that compared to men, women were more likely to be admitted to a medical unit. And this is in a multivariate analysis, which was including age, sex, ISS, Charleston comorbidity and low fall. And so, and also people who didn't speak English were more likely to be admitted to a medical unit than a surgical unit. And, you know, I think this is all coming into this challenge that there is still a lot of unknowns in what's the right model of care. And I think people are really trying very much to do their best for these patients. And I know that there is a lot of concern sometimes when they're medically complex about how they're going to go under a surgical unit, although as in our service, they are lucky enough to get medical and surgical, and also obviously trauma sometimes run at really high numbers. And so, you know, when you account for all these things, it did appear that people admitted to a medical unit did have a higher risk of mortality. Having said that, we couldn't account for all factors in our analysis, and I know there's some data out of Singapore showing that people with a low fall were much more likely to have another cause of death like sepsis as the reason for it. So there's probably a bit more exploring to do. But I think it does highlight the need to think really carefully about going back to what Maya was talking about and how we're triaging these people, how we're determining where people should go, and also about thinking really carefully, you know, whenever you are putting in these care standards, particularly considering we work at a statewide level, comparing these variables, comparing who's doing what well and what we can learn from it. And so these two were the cause of my last low fall. I missed a day of yoga. So, you know, I was not severely injured because I'm luckily not frail yet. So, you know, and I think within this, I think that what I think the takeaway from this is that, you know, and going back to this poor man I saw, you know, lying on the footpath, completely unable to get up in terrible pain, you know, is it time that for the older people we take away the mechanism of injury as a thing for severity? Do we need to set that aside and just do these individualised assessments, thinking about their injuries? And I know there is concern about how many people end up getting pan scans, but you know, sometimes if you've got an older person who's hard to localise, who's confused, it's hard not to do these pan scans, and maybe you're going to actually end up with a better result and maybe going faster. And, you know, I've always kind of thought that the low fall group were, you know, very self-selected in not having as much reserve to recover from their injuries, but maybe there's other issues going on in terms of triage or getting to hospital in time or getting the injuries managed, you know. Is it because there's differences in how we look at this group that we need to reframe trauma in this age group and do things in a bit of a more timely manner for this group? And, you know, we've seen great success in the orthogeriatrics model, which has got really standard quality criteria, which has reduced mortality. And so it makes me think, you know, this group said they're self-excluded from trauma triage tools. Do we need to do more? Now they're making up such a high proportion of our group. I feel like there's a great need for the research collaboration, not just in Australia, but internationally, to get better at working out who needs what and for the right models of care. Right, thank you, everyone.
Thanks, Kate. So next is Rachel Aitken, who's a geriatrician and general physician with a special interest in the perioperative care of older people, and she's also one of our trauma geriatricians, and she's the co-lead of the top service here. She's going to be describing and telling us about the trauma of the older person service, the first in Australia.
Thanks, David, and yeah, thanks again for the opportunity to speak tonight. We're really excited to talk all things TOPS, which is our acronym here at the Royal Melbourne for Trauma in the Older Person Service. Ooh, wrong button, there we go. So just carrying on from Kate's talk, just reflecting that geriatricians working in the trauma centre in the space is rapidly evolving over recent years. So we're seeing this not only clinically, but there is also some research to support this. So just showing that some of the papers we refer to show geriatrician involvement and within a multidisciplinary team leading to improved outcomes for our older cohort, be that reduced delirium, readmission rate, reduced length of stay, and there has been some association with a reduced mortality rate. And here at the Royal Melbourne, we're very lucky and fortunate to launch our top service in January 2021 on the background of a historical geriatrician registrar consult liaison model of care that had been going on for many years. So we were thrilled to launch at the time. We had a shared care model with a resident registrar and consultant, which we've really enjoyed a good working relationship ever since. And then 2 years ago, approximately now, we were then thrilled to launch our own bed card, which has evolved into a hybrid model, which I'll describe further. So essentially we have both shared care, which we were initially providing, as well as our primary bed card unit. And all older patients are admitted under the trauma service, where we will then self-refer, so screen all patients over the age of 65 admitted under the trauma service, and we'll see them routinely every day. But we also try and be flexible, so if there are younger patients with geriatric syndromes, we've got a good working relationship, very happy to see those patients as well. And really what we're hoping to deliver and aiming to deliver is that really early assessment, and that we call it a front-end comprehensive geriatric assessment, which is the bread and butter of what we do as geriatricians. So really getting in there and thinking, this person in front of us, what are their goals and values? What are they hoping to achieve? Are their goals of care aligned to that? And often it is a bit of detective work and collateral history, and some of those early medical issues that do frequently present for our older cohort, such as falls assessment and medication management. At approximately the 24 to 48 hour mark, some of the patients do transition to our bed card, and we have some predefined criteria which we have defined, but we try and prioritise the group that really will get the most value. So are they from residential care? Do they have advanced geriatric syndromes? Do we predict they're going to have a complex, lengthy stay? But again, it's a day-by-day conversation and an evolving space. So I'm really lucky to work amongst a wonderful group of colleagues in the geriatric medicine department. So Professor Kwang Lim is our head of unit and really a visionary for why our service exists, putting in the business cases, evolving those relationships, and allowing us to be an early adopter. All four of us geriatricians have been there since 2021. So we have Dr. Michelle Prio, who I think is in the audience, Kate Gregorovic, you've heard from, myself, and Dr. Ross Bicknell. And this is what our junior medical staffing looks like now. So because we are a bed card unit, we have a 7-day-a-week resident cover service. So 8 a.m. till 9 p.m. Monday to Friday, and then till 4 p.m. on weekends. And our advanced trainee, and we're very lucky to have some exceptional advanced trainees with us, work the usual hours, and we also have an advanced trainee 8 till 12 o'clock on weekends. As part of launching the TOPS bed card, we've also evolved our after-hours consultant cover. So our geriatric medicine unit has a subacute and acute arm now. So there's always a geriatrician on call to support our team. And I think on reflection, 2 years on, what's working well, and really what keeps coming up is the really excellent working relationship between the trauma team and the TOPS team. Of course, there is a lot of variation because we have a lot of junior doctors rotating through, but when things are really working well, we notice that actually, the two teams are communicating daily. There's the paper rounds that are happening and lots of relationship building. So we've really enjoyed that as geriatricians. We share our multidisciplinary team, which has been an absolute positive, so that continuity of care, no matter which bed card they actually flip under, and obviously working with a team that have a lot of expertise in both the injury management but also the geriatric syndromes. And again, we're happy to provide medical advice. We're able to, the trauma team, and the trauma team always very kindly offer us lots of surgical assistance. So for example, the other week we had a patient we took over care of that then went on to develop a nasty ileus, and trauma team are there every day, prescribing fleets, doing rectal tubes, you name it. So we're very lucky. And again, the trauma team resident cover will then extend after hours. So again, that continuity. And finally, I think it's really important that our morbidity and mortality and our governance is reflected together with the trauma team. And some of us attend the meeting every 3 months. We present cases, and so that's been another way we've been able to learn together. So I've rabbited on a little bit about comprehensive geriatric assessment, which some of you might not know what that is. That's CGA, we call for short, and that's kind of what we do as geriatricians, and we can apply that to all sorts of different settings, whether that's a trauma patient, whether that's a dementia patient. And you can see the boxes in blue are kind of the domains that we think about for all comers. Whereas the peach, perhaps the older trauma patient we might routinely think about, and lower down, it's really a highly individualised assessment and intervention that we can adapt to the needs of our patients. And just again, Kate had mentioned that we've got this really grounded evidence base for geriatricians in the perioperative space from orthogeriatrics. And yes, there's a lot of similarities, but the other difference between orthogeriatrics and trauma is the heterogeneous group of patients who have heterogeneous needs. So obviously not everyone's going to have surgery, not everyone's had a low fall, and you don't have to read all the detail here, but just some case examples. You can have your very older patient with lots of geriatric syndromes, very functionally dependent from residential care, have a fall from standing height, versus somebody who's just starting to fall off the wagon, developing some geriatric syndromes, and actually this patient might not recover as well and their rehab needs might be a little bit more complex than patient number 1. And then, of course, we have our more robust, often younger patient who might have a slightly different mechanism of injury or maybe not. We have a lot of road bike accidents, as I'm sure we all do, and perhaps a bit more of an unpredictable recovery journey. So coming back to, I've called the case Mr. SC, but I think we've all got different names for the case. But just coming back to that history and what do we do, and we're the TOPS team and we go and meet this patient for the first time. I think when I read this history, I had lots of questions. So I think there's lots of red flags that we think of as geriatricians. Well, why was he up a 4-metre ladder? Did he plan that? I read that the footing was in the garden instead of the concrete. Well, what was unsafe about the garden, and why did he make that decision today? And also the ladder gave way. Did the ladder break, or did he overbalance? Did he have a medical episode or a syncope at the top of the ladder? And the fact that he doesn't remember the fall, but then no loss of consciousness. I always get a bit, if they didn't remember the fall, did they remember hitting the ground? Was it syncope? And but actually could have he had a head injury, and that could have confounded things. So just some of the things that we're thinking of. And, as geriatricians, we divide falls risk factors and precipitating factors into little different categories, and there's some of the things we'll be thinking about. And then when it comes to the medications and medical history that Kate already touched on, again, someone's had a fall. Well, how recent was that escitalopram? What bigger dose is it? When we do a meta-analysis, when we're looking at a single medication, antidepressant is one of the biggest falls risk factors. Tell us more about the BPPV. How did he recover from the total knee replacement, rather? And then on the back of our minds, cardiac, respiratory status, metoprolol, how's he faring, blood pressure and heart rate wise with that, and what can we stop, because we always like to stop things. And then, yes, coming back to our bread and butter, the comprehensive geriatric assessment, we're always screening for things like frailty, cognition, function, continence, nutrition, mood, and we try and use objective tools when we can. And just pointing out that we really think it's important to put a bone health plan together for this group of patients, particularly for those that have had low falls or that we've found occult fractures on imaging. So that's always on the back of our minds, and we've liaised together with the endocrinology team here before to try and come up with some guidance. And just showing you an example of, we do have a bit of a TOPS checklist which we've embedded in EMR, just highlighting some of the things that we think are important to remind ourselves to check. And again, trauma do a lot of these things as well, and I think we work together with slightly different lenses and double checking some of the same things sometimes, but I think it's working out really well for our group of patients and delivering good care. Certainly establishing collateral history and establishing rapport is a really important value add. Identifying the medical treatment decision maker, and again, goals of care planning, discharge planning, which we're going to hear a whole lot more about. So just finally, Kate's already reflected on what's next for this space, and I think what we did find, so I presented at the Geriatric Medicine Conference in May at our perioperative day with Dr. Margot Lodge from the Alfred, and Kate has recently presented at the Australian New Zealand Trauma Society, I think with Dr. Margot Lodge again. And really there's just been this appetite for what next, how are we going to really establish a framework for this group of patients who we've all identified as such an important group of patients, so commonly presenting, and how do we reduce their variation of care? How do we ensure our non-major trauma centres are supported to care for this group of patients? And certainly there's been a lot of appetite for a interdisciplinary binational trauma framework, and I think there's been some steps towards what that might look like, and obviously some local research development as well. So thanks very much, and looking forward to the panel.
Okie dokie, here we go again. You get me again. And I've got the Jerry Girls and Boys. It's a community of practice that recently formed at the ANZTS meeting who are active on the WhatsApp at the moment. So if you want to join that little community of practice, let me know at the end and I'll add you to the group. Okie dokie. Let's wait till mine comes up. Thank you. So let's go back to our case. So day after admission, our patient, Mr. SE, comes up to the ward and he's actually in the neurosurgical high dependency ward initially. And you can see here during the course of the day he's seen by multiple teams, and we do very much front end. It's actually Sue Lou, one of the orthopaedic surgeons at the Alfred, taught me many years ago with old people, if you're going to do it, you go hard, you go early. You don't wait around deciding when you're going to do it. So seen by trauma, I won't read out everything there, I'm sure you can all read, but also very early on, our TOPS team have seen him again as well as day one. Physiotherapy, the neurosurgeons see our patients very early, sometimes about 6 a.m. in the morning, maybe a bit too early. Acute pain service, a really important component of our patients' care. Thoracic surgery as well, even though we are doing less rib fixation because of our very well-established and more mature multidisciplinary approach to chest wall injury. I think it's probably our older folk that have benefited the most from such a pathway and the early involvement of that group. Trauma came back and did the tertiary survey later in the afternoon. And a really important part of that too, even though, yes, TOPS have been involved and there is a lot of overlap, but it's where we sort of bring things together and the consideration for where this patient is on their journey. Are they entering those sort of final years of life, or is this just a little bit of a hiccup along the way? And an evening neurosurgical review of a repeat CT of the brain, which we're able to de-escalate the frequency of the neuroobs. So as you can see, this continues. The patient then moves on to our trauma ward, which for us is the 7th floor, 7 South. Deep breathing, coughing is okay, but he's still very sore. Bit clearer in the head, maybe a bit confused a bit earlier. Functional activity, according to APS, was though pretty good. Functional activity score of A. He could, the PCA had been working well, and they felt it was no longer needed. Physio, it's really important to get these patients up and moving early, clearing the spine. We aim to do it before the patient leaves the emergency department in most situations, and getting them up and trying to mobilise, not letting them sit around. I think, again, it was Sue that taught me older folk are like horses. If they lay down, they die, so don't let them lay down. No matter what they say. And then you take the sheets off the bed once you get them out of bed, and they can't get back into the bed till the sheets are back on the bed. I think Lara Kimmel taught me that one. Occupational therapist, so this is really important too, and a bit of collateral history, and we get the OTs to dive a bit deeper. Well, maybe our patient wasn't as crisp as what he had, and it turns out his wife started to do most of the higher level executive functions with regards to running the home, appointments and things like that. Over the next few days, he progresses relatively slowly on the ward, I think it's fair to say, and takes a little bit of a backward turn. Pain control is an issue. And he ends up needing an erector spinae blocked or an ESB. He has developed decreased air entry in that right base, and his mobility is quite significantly sort of hampered by pain, and he's quite unsteady and needs support and watching. Whilst he's eating reasonably well, he still hasn't used his bowels, and we're getting on to day 5 now. And then over the next couple of days from that, again, now develops a productive cough. Cognition is probably a bit worse, particularly of an evening, and he's still got quite significant restrictions in his mobility. And whilst he's sitting out of bed much of the day, he does need a lot of assistance to get there and needing a frame. There is an improvement though in his pain with the ESB. He's able to deep breathe and cough much better as well. But he is still constipated, so he gets everything, the Movicol, and I think from memory we actually threatened him with the fleet enema, and I think he took one look at it and that was it, and he pooped. Occasionally it happens. Alrighty, and then he eventually developed pneumonia, increased CRP, chest x-ray changes, but we treated him with oral antibiotics. We didn't really go down the IV pathway, and he was confused at this stage. His ESB was also disconnected at about this time. And so it was decided not to put one back in at that stage. And over the next day or two, things did then turn the corner as we got on top of his chest sepsis. Confusion settled down as well. And I think one of the things, and we were able to then, with the help of TOPS, and I think whilst we use our TOPS unit and trauma work very well together, TOPS are also really helpful in helping us to coordinate and advocate for the patient to head down the ACE pathway or the GEM pathway from that point of view. So they're strong advocates for our patients from that point of view. And it's really, and what I'd like to say, a lot of our patients, once they do come out of that fog of delirium, is that they know they were confused and they sit there and they're often very apologetic, and I often feel sorry for them at that stage. Like, it's okay, you know, we know they're going to get through there. And he was able to get home as well, so he didn't need to go anywhere else, he was able to get home. And whilst our patient did have a high ISS of 26, you know, we use these figures, I think, with a bit of caution. These figures and the use of using injury severity score is to anticipate mortality, but they were set up in young people having predominantly motor vehicle incidents, road trauma patients. So we still do use it, but I would sort of question how valid is it in this patient cohort, and does it really help us to make treatment decisions? I'm going to end there. We're going to have a few more talks as well, and I'll wrap up the case at the very end.
Thanks, Kate. Next, I'll invite Kelly Lurch, one of our trauma clinical nurse consultants here at the Royal Melbourne, to the podium to talk about the acute ward care of the elderly trauma patient. Kelly's been nursing for that long? Okay. Did you start when you're 12? Yeah, maybe. Yeah, okay. For an undisclosed long time, with experience in head and neck oncology, reconstructive and plastic surgery, orthopaedic and trauma nursing.
Thank you, everyone. I won't disclose my age, but I'm getting towards a milestone in a couple of weeks, so thanks, David, for reminding me of that. So thank you for the committee for asking me to speak tonight. I think it's really important to represent nursing as playing a major part in managing our patients in a very acute care setting. And we've heard from Kate and Maya and Rachel this afternoon actually, about how the models of care can really impact our trauma patients. So, you know, with any of our trauma patients, we're really aiming to identify and manage their injuries and prevent their complications to provide holistic care. But as we've heard, for this particular age group, we know that they have an increase in mortality and morbidity. So nurses can play a huge role in preventing, I think, particularly complications. And it can prove very challenging in the acute care setting. We've heard from Rachel with thanks about gaining baseline, and I think it's also important for nurses at the bedside to understand the patient's premorbid abilities, and that can really help us identify if there is any change in their function and their cognition, which Kate has demonstrated in the case already. Understanding their alcohol, tobacco and any substance use as well can also really influence how we manage and change the management of our patients on the ward, you know, day 2, day 3, particularly into their journey. Also, understanding the medical comorbidities as well can really influence the strategies that we can use from a nursing and allied health perspective, and what are the goals that we're trying to achieve with our patients in managing them. Rachel has also talked about, you know, managing the decision makers, establishing if there is advanced care practice, and from a nurse at the bedside, understanding our goals of care and where we're headed is really important to incorporate into our nursing care. All of this information can be gained really easily by just asking some really simple questions, and I think nurses can play a really lead role in this. We're with the patients 24/7. Quite often, if their family and their next of kin are visiting after hours, we can be the key people that can ask the simple questions. How far could you walk? Was the patient managing their own finances? Were they driving? What were you doing for work? Or were you cooking and cleaning yourself? Were you able to shower and toilet yourself? All this is really information that we can gain by asking simple questions, either to the patient, ringing their GP, you know, speaking to residential aged care facilities. Also, understanding their current home situation, I think, is very important as well. Were they receiving care services? Do they have close family and support services close by? Or were they actually the caregiver, which has now left someone at home that isn't receiving the care that they normally would because their carer is the patient in hospital? This diagram that I've sort of thought about is really about prevention, and I think nurses can play a lead role in preventing many of these complications that we've touched about in our presentations earlier. And one thing leads to another pretty much, so that's why I've interlinked a lot of these. So as we've sort of spoken about, delirium can be affected by urinary retention, constipation, malnutrition, pain, respiratory complications. That can also influence falls, VTE prophylaxis and pressure injuries. So we can play a major role in trying to prevent a lot of these complications. But in this older cohort, it can be very challenging in the acute ward. So we've heard about our patient, and basically to summarise, we know that he's predominantly got head, chest and some superficial skin lacerations and abrasions. So the key nursing things that I'm thinking straight away is understand his GCS. What is his risk of post-traumatic amnesia? What is his baseline cognition? And is testing using the AWOPTIS and post-traumatic amnesia even actually really appropriate for this patient? What's his baseline? Is this a delirium? Is this a change in his cognition and his behaviours? Because we have seen some changes with him becoming more confused and restless during his stay. His spine has been cleared, which is great. We can get him up, get him moving and sit him out of bed. But has he been able to effectively participate in deep breathing and coughing and chest physio? Are we assessing his pain appropriately compared to his cognition? And are we providing him with effective analgesia that is managing his pain to enable his function? We understand he's got some acute wound care needs that we need to attend to and plan a wound plan. But are we preventing pressure areas, and what's his risk at developing these? We've spoken about constipation and urinary retention and malnutrition and the risk of these. So what are the risk screening tools that we can use from a nursing perspective to get a good baseline and identify his risk and put the management strategies in place to prevent them? Again, as we've touched on, what's his baseline with regards to his mobility? Does he use a gait aid at home? And what's his likelihood of being a high falls risk in hospital in this acute care setting? So lots of considerations when our patient's being transferred from ED or from the HDU area. We know that delirium is a really high risk in this patient cohort, and it's a disturbance of attention, awareness and their cognition. And this can develop within hours to days and obviously fluctuate throughout the day, throughout the course of the day. Our patient, being 74 years, has a 14% increase in risk in developing delirium. So really important that we try and put some strategies into place to prevent this, because we know that this has associated with worsening cognitive and functional outcomes. The 4-at rapid test for delirium is something that we use to early in the patient's stay to identify their risk of delirium. But we know that our patient has started off okay, being cleared of PTA. He's got a fairly good baseline at the moment, but over the days of his admission up to day 11 has become worsening with his confusion and agitated and confused, particularly overnight. So very, likelihood that he has developed a delirium. A lot of the triggers for delirium, unfortunately, in the acute care setting, it's very difficult to manage. So we are constantly waking people up during the night to do vital signs, to assess their pain, to administer IV antibiotics, to attend to their other needs. Our patient is likely to be hypoxic. We know he's got a chest infection. He's probably got uncontrolled pain. He's likely to be dehydrated and also has the risk of urinary retention and constipation. So tailoring, as David said, the needs of the older patient can be very difficult in this environment. It's really hard to get natural light in a hospital and an old hospital such as this with very limited windows, and particularly if the patient is not placed right next to the window. The high fluorescent lights are very challenging for patients to have on, so they like the lights to be turned off. We come in the morning and flick them on because we're getting old and we can't read our handover sheet. That's usually my number one job in the morning on ward rounds. So distinguishing day and night for patients, it's really challenging in this situation. Maintaining their sleep-wake cycle, a lot of the time they're up during the night and they're sleeping most of the day. If patients in post-traumatic amnesia, we try and not change that, but in someone in delirium, we want them up during the day and we let them try and sleep during the night. Simple things such as just making sure they've got their glasses and their hearing aids is really important as well. You know, a lot of patients, if they fall from a height onto their face or involved in a motor vehicle crash or coming from regional areas, they may not have their glasses and their hearing aids with them. And probably the number one challenge in tailoring our care and our needs in this acute care setting is the bed space. So a lot of our patients are in shared rooms. We have lots of acute equipment within that room, which creates a lot of clutter in a very small space. So for nurses, pain assessment is vital, and we'll talk a little bit more about that, and providing appropriate assessment and management. Optimising our patients' mobility to be able to sit out of bed and mobilise even to the bathroom is really important. Preventing the constipation and creating a toileting regime, and rationalising the invasive devices. A lot of our patients in this acute phase have cannulas, drain tubes, catheters, all different lines in. Sometimes they have mechanical restraints if they're becoming more and more restless and agitated. And I think it's important to advocate. So as bedside nurses, we need to advocate for these patients, be on the trauma round to say, do we need these lines? You know, can we take them out? How important are they? Chest injuries, we know, we've spoken about the increased mortality and morbidity in this age group compared to our younger age group. Our patients, we know, have a 31% chance of increased pneumonia compared to our younger age group, and our patient in this case has developed pneumonia. So trying to assess their pain can be very challenging. They have cognitive impairments, communication issues, and they might not be able to effectively communicate their pain using a pain rating scale from 0 to 10. And a lot of our patients have language barriers where their English is not their first language, so an interpreter may need to be required. Pain assessment tools, there are many of them. As you can see with this clip here, our patient here, Mr. S, has rated his pain as 0 out of 10, but he's unable to move. It's 8 out of 10 on movement. And that's a really common thing that we see. Patients will say, no, I've got no pain if I don't move. The key is we want you to move. We want you to get up out of bed. We want you to deep breathe and cough. So maybe the functional activity score is a better assessment tool for our patient, asking him to deep breathe and cough, asking him to move in bed and sit on the edge of the bed. We get a better idea of his limitations related to pain rather than rating your pain from 0 out of 10. Pain management can be pharmacological and non-pharmacological, and we're going down many of the multimodal analgesia which our patient has experienced, starting off with simple analgesia, adding a PCA. Now, if our patient's cognitive ability is impaired initially or is declining, we need to ask the question, is the PCA the most appropriate mode of analgesia for our patient? Both from a cognitive perspective and a functional perspective. Can they even hold the button in their hand and effectively press the button? Have they got some arthritis that's preventing them to do that? We can see that our patients moved on to a regional block, which seemed to be really effective mode of analgesia for our patients with multiple rib fractures. The non-pharmacological methods that we can look at are high flow oxygen, providing some humidification to allow our patients to be able to excrete their sputum a lot easier, and also providing splinting, rolled towels, and the education to go with that to enable the patient or their family at the bedside to encourage them to deep breathe and cough and sit out of bed. As we've talked about, constipation is a major challenge with any trauma patient. We conducted a study here with Kelly and David looking at our trauma patients when we had 76% of our trauma patients were deemed to be constipated, with multi-system trauma patients having a threefold increased risk. Add in there with our physiological changes with ageing, our decreased mobility, our polypharmacy, change in diet and fluids, and our changes in our toileting abilities, puts our risk at very high for our patients, which can ultimately cause delirium, as we know. So as Kate explained, our patient didn't open his bowels till day 7. Along that track, he was only on PRN aperients. So let's be proactive and not reactive. That's my little motto. Let's get regular aperients to be ordered rather than PRN, because as nurses, I have to say we're not very good at administering PRN and aperients. Also, I think a really important thing is enabling the patient to get to the toilet to open their bowels is a really big psychological factor that many patients and in the literature actually describes. So if the patient has no lower limb injuries and is able to walk to the toilet, provide them with the time and the assistance and the supervision to actually walk them to the toilet rather than giving them a bedpan. High falls risk goes without saying, and the challenges to adapting our environment in this very acute care trauma ward is challenging. The environment, the equipment, the lighting, the communication, and considering, does the patient actually need a high visibility area? Do they actually need a special because they're becoming very impulsive and agitated trying to get out of bed? Again, the clutter is a huge issue. I hate clutter. The first thing I do is remove all the towels, the sheets, the blankets that are gathering up around the bedside. Obviously poses a really high risk for all of our patients. And some of the nursing care we've already discussed. Another really important factor that I really want to just touch on and bring to attention is that 25% of our patients over the age of 65 are not from Melbourne. Being a major trauma centre, we have a lot of patients that come from regional areas, and this can create a loss of independence, which can often also affect their functional and cognitive decline. Engaging the families is really important at this phase. They can help us to prevent a lot of these complications, and sometimes it may just be increasing the flexibility of some visiting hours, talking to the nurse unit manager to say, can their family come in, help with feeding, help with chest physio and allied health sessions to try and get the patient moving through their journey here. I'm going to hand over to our allied health colleagues in a moment, but early referrals to our multidisciplinary team is essential. It helps facilitate, we can all work together. It helps facilitate and prevent our complications, putting strategies in place, engaging the family and trying to find appropriate discharge planning for our patients and getting them back to closer to home if they're from regional areas. So in summary, I just want to highlight some of our key nursing challenges. I think for nurses, we're on a trauma ward, but we also need to improve our understanding of the physiological changes of nursing the older trauma patient and how this can impact on what we do. We've highlighted several times assessment to gain baseline information can be very useful for all of us to help plan our care, but also prevent complications. Trying to adapt our environment and our competing demands from a nursing perspective when you may have 2 or 3 other patients with really high care trauma needs as well can be very challenging. Engaging our family for discharge planning should also be really highlighted, and nurses should be key in facilitating that. Thank you very much.
Thanks, Kelly, and thanks for highlighting our shared passion, mine as a colorectal surgeon, of the second ABC of trauma, are the bowels constipated. So double trouble next. We have Jess and Kira. Jess is a senior trauma physiotherapist here at the Royal Melbourne Hospital, and she's worked at trauma-related units both here and in the UK. And Kira O'Brien's our senior trauma occupational therapist with specialisation in brain injury assessment, spinal cord injury and rehabilitation. She's here at the Melbourne, but she's also worked in the Royal Darwin, go the Territorian. So they're going to speak to us about discharge planning.
All right. I'm Kira, so I'm one of the OTs.
And I'm Jess, one of the physios.
And we're going to be talking about discharge planning in trauma in the older patients. So some of the aims of discharge planning is to ensure appropriate supports are organised post-discharge. It's to decrease the length of stay, preventing readmissions, and improving patient and carer experience. Some of the challenges that we experience with discharge planning is that it's hard to teach. Every patient is different, no one's the same. It's ever changing. It differs between health services to what services are available post-discharge, and it's more challenging in older patients.
So in our older patients, there's lots of considerations we need to think about when we think about discharge planning. So this is by no means an exhaustive list, but a few to discuss. Our first one will be their geographical location. I think Kelly and some other speakers have also mentioned that we get a lot of patients from all over Victoria, being one of our state trauma centres. So our discharge planning can really depend on whether they're in our local catchment or if they are rural or remote, that can really affect their service provision.
And Kelly touched on this before as well. If the patient has any pre-existing cognitive impairment or intellectual disabilities, will they pass post-traumatic amnesia testing at baseline? Are they experiencing any concussive symptoms that may be impacting their function and participation in the activities of daily living? And are they currently in a delirium?
One of my favourite topics, and I think Lara Kimmel's favourite topic as well probably, is weight-bearing restrictions in these older patients. So we know that it's really hard for our elderly patients to maintain weight-bearing restrictions. In fact, we know that in one study, 22% of patients more than 65 weren't able to do that in a lower limb fracture compared to 73% in those that are less than 65. And that number decreases even further the older we get. So at 75, only 5% of patients were able to maintain their weight-bearing restriction. So something really important to consider when we think about discharge planning.
Another consideration is if the patient is required to wear a collar on discharge. So is the patient able to manage their own collar care? Are they able to do that independently? Do they have someone at home to assist them? And there are limited services available on discharge to provide that daily collar care. So that's something that we also need to consider. Another consideration is if the patient is required to wear a sling, are they one arm down, how that may impact their participation in their activities of daily living, especially if their dominant upper limb is impacted. And does the person require assistance from services such as home help and donning and doffing their braces?
Also, especially in our trauma patients, their funding stream is quite important, where they might be covered by our compensable units, so our Transport Accident Commission or WorkSafe, or whether a public patient can really differ between what services might be available to them if they do discharge home, but also what kind of rehab services they might be eligible for.
Another consideration is the patient's home setup and if they have access to safe housing. So do they have stairs that they need access to enter the house? Are there stairs throughout the house? What their bathroom setup looks like and the location of their house. Are they able to access the community?
Again, also been touched on by our last speakers, I think, but especially important in this population is whether they're a frail patient and what their falls history is. We know that pre-injury frailty is a predictor of poor long-term health-related quality of life in this population. So when we're thinking about whether patients are appropriate to go home, that's something we consider, but also important to consider what services or specialist clinics might be appropriate to refer them to if they do go home, and if we can prevent readmissions from further injuries.
We also need to consider their mobility and equipment needs pre-morbidly. So did the patient use a gait aid previously, and did they have any other equipment in place at home?
And we know a really important part of discharge planning is involvement as a multidisciplinary team, but also having the patient and the family, I suppose, as part of the healthcare team as well. So NDPT meetings we know can help to decrease length stay by about 15% in this population group, and also really important to know what the patient's goals are in relation to getting home. At RMH, we have a couple of specialised allied health services which can help with these complex discharges. One is our disability liaison officers, which are really helpful in patients who have a pre-existing disability, and connecting those dots, I suppose, of our services in the community that they might have pre-existing to our services that we can provide from the hospital. And we also have a group called the Flying Squad, which composes of physio, OT and neuropsych of differing levels of EFT, which can help with those really complex discharges where there might be a gap in other services that we can try and get these patients home rather than have them stay in the hospital.
Lastly, another consideration is if the patient has any family support at home, they would be able to assist on discharge, or if they've got any pre-existing services through home care packages or private providers.
So when we take into account all those considerations, I suppose our first point of contact to think about is whether the patient's not safe to discharge home or whether they are safe to go back to their house or whatever their usual place of residence might be, which might be a residential aged care facility in this instance. So at RMH, we probably get about 70% of our patients over 65 directly home admitted to trauma or our TOPS unit, and about 30% need to go to some kind of rehabilitation or acute transfer. So this is a busy slide, but bear with me. So if patients aren't safe to discharge home, this is again not exhaustive, but we have a lot of patients that need to go to our geriatric evaluation and management unit, or our GEM unit, which is more of a slow stream rehab for patients who might need a little bit more time to achieve their goals. We're lucky with our geriatricians from our top service that we have the ability to green light people to GEM, which means that they get rid of a lot of wait lists related to that, which is really helpful. A lot of our patients in TOPS still go to inpatient rehab, and that's especially true with our private population who might be through TAC. As we're speaking about, I think with other speakers, a very variable cohort, so we do still get a lot of fit and active elderly people who can meet the requirements for that. We do get a lot of patients that are from not interstate and in-country areas, so we do refer a lot of patients back to their local hospital where they can get ongoing medical input but also be closer to services in their local area. We do have our acute care of the elderly service here at Royal Melbourne, which is, I suppose, an acute kind of rehab with an anticipated length of stay less than 7 days. And again, that's something that our geriatricians can be really helpful at getting our patients to quite quickly. Less likely, but we do still refer sometimes to our transition care program, bed-based or restorative care, and that might be especially true for patients who are a bit more elderly, who might be non-weight bearing, who we don't think is going to get home in that 6 weeks that they can't put weight in their leg, so they might go there and have nursing care and wait out until they're able to. We do also send patients to respite. If patients are safe to go home from the acute service, we do have, again, a number of services that we can refer them to try and prevent readmissions and also make sure they're supported in the community on their discharge. So our first one is our RMH at Home service. You might be called Better at Home or have an equivalent service at your own health service, which is essentially a bed substitution model for rehab. Can be kind of at a GEM pace, which is a bit more slow stream, or at a kind of rehab pace. TAC have a similar program for their patients who are funded by TAC, which is a rehab at home program. We do refer a lot of patients to our post-acute care service, which can be nursing, physio, home help with cleaning, or help with showering for a short period after their discharge from hospital to try and get them to that hump where they can use other services. We send a lot of patients for private follow-up for allied health, so that might be speech pathology or dietetics, social work, physio, occupational therapy. Obviously, we can refer to my aged care for ongoing services or allied health if that's required, but there can often be a long wait for that, which is why we might utilise some of these other services. We often refer to community rehab or community therapy services for longer term rehab. Our nursing colleagues refer to Bowles and Clark quite a lot, which might be for wound management or could be for collar care. We have a lot of patients that might come in with a low fall, as we know, or might present with concussions, so we do often refer to specialist clinics as well. Our social work colleagues may refer to crisis accommodation or housing services as a way of trying to get patients out of hospital as soon as we can in a safe way. And we do also sometimes refer to our transition care home-based program.
Now we're going to talk about the discharge plan for the case study, Mr. S. So Mr. S, as you can see, he was at home living with his wife. He was very active in the community. He was independent with all his activities of daily living, and he was mobilising independently for about 45 minutes every day. And he had supportive children that live locally.
So if we go back to our discharge considerations and put them in the context of Mr. S. So Mr. S lived in metropolitan Melbourne, although he wasn't in the RMH catchment, but that does mean that he was in an area where he was able to get services if he needed them on discharge.
As discussed before, Mr. S, he cleared the abbreviated Westmead PTA scale with the nursing staff, so that was administered within 24 hours post-injury. He had some brain changes, and due to those brain changes, the OT completed a cognitive assessment. The cognitive assessment that was chosen was the RUDAS, and Mr. S scored 24 out of 30, so he scored full marks in everything minus his memory recall. After conversations with his wife did report that the patient's memory wasn't always best at baseline. However, it is worse than before, so the OTs went through some cognitive retraining on the ward, providing external memory strategies and education to both him and his wife.
Luckily for allied health, he didn't have any weight-bearing restrictions, no braces or slings, and was a public patient. So they probably weren't really big considerations in terms of our discharge planning.
Yeah, Mr. S lived in a single-storey house with 2 steps at the front access, and he already had a rail in situ, which was a great protective factor for him. His bathroom just had a standard shower recess, no equipment or rails, and there was no steps throughout the house.
I think, as mentioned before as well, his clinical frailty scale was 3, so he was managing previously relatively well, and as we know, this was a high fall, didn't have a history of low falls in the community.
As we said before, he had no equipment and he wasn't using any mobility aids previously before coming into hospital. And at the time, he was currently mobilising supervision with a 2-wheel frame.
In terms of multidisciplinary team meetings, given the fact that this patient was still needing assistance with mobility and had some ongoing cognitive concerns, it was deemed in conjunction with the family that he wasn't safe for discharge home at this point.
And he also had no services in place previously, and his wife was very supportive.
So taking into account all those considerations, it was deemed by the MDT in conjunction with the family that this patient would benefit from that really short period of allied health intervention, geriatrician intervention up on our ACE ward, given those factors that he still needed some help mobilising, had ongoing cognitive concerns, and that we anticipate his length of stay would be less than 7 days.
So overall, Mr. S, he spent 4 days in our acute care of the elderly ward before he was safe to be discharged home with services and equipment. So Mr. S's function on discharge was mobilising independently with a 2-wheel frame. He was independent with toileting, but he still required minimum assistance ×1 from one person for his showering and dressing due to pain using a shower chair. So equipment was provided through our post-acute care service for 30 days for hire. So he obtained a shower chair over toilet frame, a high back chair and a 2-wheel frame. And as he needed that assistance with showering, he was referred to post-acute care for personal care assistance and physiotherapy for 30 days. And then post those 30 days, he was referred to community therapy services for ongoing OT and physio.
So I suppose our take-home messages from a discharge planning point of view is that, it does differ a lot between health services and locations and can be affected, especially in our trauma population, by their funding stream. MDT discharge planning achieves the best outcomes, and having the patient and caregivers involved in that process and as part of the healthcare team is crucial, especially in this older population. And I think this has been mentioned a lot throughout the presentations as well, but this is a very variable cohort, and there's very different discharge considerations in our 70-year-old active bike rider versus our frail elderly patient. Thanks.
Okay then, I think I've only got one more slide to really to wrap up, and I did try to anticipate what the key messages were, and I think it's all worked out. There was we kind of knew what everyone was going to talk about, but I think I almost got it. So I think the take-home key messages from the case we've presented you this evening, as well as the specific particulars with each of those aspects, and thank you very much to all of our speakers, they were awesome talks, is that the older folk need a lot of resources, and they need these right from the beginning, okay? And it starts down in the emergency department, physiotherapy, TOPS, etc. Even with the best care, early spine clearance, early mobilisation, what was initially thought to be adequate analgesia, pneumonia and delirium still often do occur. We do need to consider the goals of care early with our elderly folk, and our geriatricians are really helpful and vital, I think, in some of these conversations that we have also. And I think what's really important, and I really like Maya's pictures at the front, and hopefully this sort of is the bookend that brings it all together, is that our older patients can still have quality of life. And I think that we may not have the duration, the length of life, but they can still absolutely have quality of life. They're someone's husband, wife, mother, father, grandma, grandpa. And I think if we bear that in mind, and how would we like our older patient relatives to be treated, and how do we want to be treated in our older age, which seems to be a theme tonight, I think, that makes it much easier to direct the care that we have. So with that, I'm going to say thanks to all of our speakers, and we're going to now give you the opportunity to put us under the spotlight and question us, and hopefully we can sort of gather some good discussion as it comes on here. And I might invite all of the speakers to come down.
Thanks, Kate. And I'll just introduce Dr. Emma West, one of our emergency physicians, who's going to help me co-chair this panel discussion.
Thanks, David. My motto from now on, Kelly, is let's get regular. That was inspiring. The first question is around clinician bias, and does it play a role when assessing trauma patients that come from aged care facilities? So I'll put that over to the panel. Do we have someone that would like to address that?
So I've been thinking a lot about how I wanted to frame my input into this panel, but I think the part of my job where I learn the most at the moment is actually in hospital in the home. So we have a huge hospital in the home service here at the Royal Melbourne. It does subacute and rehab, but there's also a very acute section. And recently we've got myself and we've got rotating ED registrars, and we go out into residential aged care facilities now in collaboration with our InReach colleagues and do trauma triage there. We even keep them there sometimes and bring them into our transit lounge where we do CT scans and make diagnoses and then take them back again. And we give excellent care without the need of an emergency department and without the need of a trauma service. And I do want to pop that in there. So many people in this audience will have nothing like the access to the extraordinary services that you guys have all described. I'm very aware that we have a very biased view here at the Royal Melbourne, and that most older people who fall over are cared for in places that do not look like this. And it's much harder to decide whether you're going to do something with somebody when you have to send them a long way to get that. And I think I have a much better appreciation of what a residential aged care facility looks like. The capabilities and capacities are not uniform, and every single decision is hard. And it requires collaboration with many more people, many more stakeholders. The ambulances don't come even when I call for them to move a patient sometimes. And getting imaging and objective testing. Sometimes I can get an x-ray in a residential aged care facility, but sometimes I have to move people. And that can be really hard in someone who's very confused, and weighing the risk and benefit for whether that is worthwhile doing is exceptionally complex decision making. So I feel like as I do this more, I know less. That's my takeaway.
Thanks, Mark.
I probably will just add too, I think we do approach our, particularly that older folk, in that it's just a low fall. They seem to be fine. Yes, they have delirium. I think it's stepping back and not treating them as a younger adult and thinking about all of those things that are, why has this person started to fall? Another term we're trying to look at the moment, rather than use mechanical fall, as in the two big Groodles or whatever they were. Whose dogs were they? They were your dogs that tripped you over. In that most of the things that will trip an older person up won't trip us up. Even me, I'm probably the oldest one at this, yes. So talking about frailty falls and that as well. So I think if we start to approach these patients with a different lens and not approach them as we do our regular adult trauma patients, we might start to see things a little bit different and look for those subtle signs as well. And I think they probably need a lower threshold to be imaged, quite frankly, but we don't have any radiologists here tonight, do we? So that's probably something, that might be another topic for another day.
Yeah, and I think that, obviously you can never make complete conclusions on observational data, but it is concerning that it looks like the mechanism of injury has such a strong influence on people going to a medical unit versus a trauma unit. And, I work in general medicine as well, and I've had such a steep learning curve over the last few years in managing injuries. And, it's a bit of a sort of what you don't know kind of thing, and so now I see it very differently. And, I think this in anything in older adults, it's really just all about collaboration and teamwork. And it's been so fantastic working with the trauma unit. We can always ask questions. Everyone's very kind, even when the questions probably seem very simple to you. And our allied health team and that expertise. And it's really all about coming together. And, there is Maya's example of being able to provide care into residential care facilities. They're getting expert care going in, and as we know, trauma statewide, and so, if mechanism of injury is impacting where people are going, or, resident rural people, I think it's really important that we do have those networks and that we do all work together, we learn together. There's ways to get consultation, because even if someone doesn't need surgery, there can be expert trauma nursing, there can be expert trauma MDT, there can be expert pain management that some services can do and some can't. And so it's really important just to all think, especially this group is growing. And so learning together how we can make sure they're getting all the best care possible.
There's actually a question related to that, and it's how do we foster collaborative, multidisciplinary decision making? You describe a system of that your TOPS unit being very collaborative. How do people follow that, model that behaviour?
Yeah, so number one, I think it's around culture plays a big part of it. And so the trauma team have been so welcoming, inclusive to the geriatricians coming in from the get-go, and that makes a huge difference. And just, communication, simple things like our trauma registrar and the trauma fellow, the unit works better when they catch up regularly face-to-face. There's a very active WhatsApp group. And so part of that as well. But, it's also having the right people with the right buy-in and the passion. So, everyone here, even if they're, other specialties like ED, are still really interested in this area. And so it's coming together. I don't know if anyone else wants to.
I think from a nursing point of view too, if you wanted to comment, Cal, is just about seeing the nursing of the older patient, particularly with trauma. It is a specialised area, and empowering nursing staff to become super specialised. I don't know if you want to comment on that.
I just wanted to add on, maybe, Emma, what your previous sort of comment or question was about, and recognising, putting a different lens on. I think our patients, elderly trauma patients, are nursed on an acute surgical trauma ward. And quite often they may be from residential care, they may not be the loudest patient, and they may not be the patient that's got the most obvious injuries, such as our patient here. So he had a head injury and some fractured ribs. He hasn't got an X-fix, he hasn't got an ICC, he might have a PCA. But unfortunately these can sometimes be the quieter patients that are sitting in the corner and don't get probably the care and respect and the proactiveness that they need. And so I think it's bedside nurses really advocating and putting on that other lens to think, and understanding that these patients have a mechanism and injury that just need as much care as the loud patient with the X-fix and the ICC and everything else going on with them as well. Yep.
So given the silver tsunami that's ahead of us, so the rapidly increasing proportion of elderly patients in our population, are we adequately planning for what's coming up in the next 5 years?
So I started thinking about this about 10 years ago, and I have to say, change is bloody hard in healthcare. I want to give a shout out to Elaine Cole, who actually is an emergency nurse and was my dissertation and supervisor for my trauma masters in London. They're up to their third edition of the management of older patient trauma. We are a long, long way behind. Elaine did a fabulous talk at a symposium we did about 5 years ago here in Victoria, and all of those talks are available online. Please get in touch if you want to hear them. I think Xuan Wei did a talk on the lessons we can learn from the hip fracture pathway. We had a great talk on what we can learn from John Olver about the difference between delirium and head injury and concussion, which we don't know very much about. So I would say we've been doing this for a long time. We've been thinking about it for a long time. It's really hard to change a system. It's really hard to change a system that was working really, really well. Our trauma system is one of the best in the world. We have amazing outcomes. And to fiddle with that doesn't feel like the right thing to do. But we have known for a really long time that the epidemiology of injuries are changing, and we need to do something about that, because otherwise we risk the successes that we've had because we've overwhelmed the system and there's too many people that we haven't figured out what to do with. So we have to change whether we like it or not. And it's taken me a long time to get happy with how long that is taking. I was working with Kate in the acute medical unit in 2015 when we started having these conversations. So I think we have to accept it's slow. We have to accept that we don't have any data really that is telling us in which direction to go in, And one of the reasons we don't have that is because all of the data that we collect is designed around a population that is not this. So the first thing we have to do is collect injury data that is about non-major injuries. We have to collect data about limb injuries, and in the older person, the biggest problem I have in the community is wound care. It's absolutely impossible to figure out how to deal with complex wounds for people who don't live near a service that provides that, and we haven't figured that out yet. So there's lots of challenges, and until we can start collecting data that isn't about major trauma but is about all of the injuries, then it's going to be hard for us to benchmark ourselves against each other, and also to benchmark ourselves against people like the UK who have been doing this a lot better for a lot longer, and also to measure our progress. So there's a lot to do, but as you can hear, there's a lot of really interested people in making that better.
I just want to add to, I think sometimes taking the broader view, there is a lot of momentum in this space worldwide at the moment. I was recently in Kuala Lumpur for the International Surgical Week. So IATSE, International Association of Trauma and Intensive Care, half of the talks were about trauma in the elderly, and the issue that that services across the globe, and IATSE really does involve trauma services from low, middle and high income countries as well. Half the talks, that's what it was about. The main case presentation for the session was about an older trauma patient. So there is definitely momentum there. Every year now there is a permanent session at the Australian New Zealand Trauma Society annual general meeting. There will be a permanent geriatric session in there looking at injury in the elderly. We've created a community of practice now from that group as well. So there is momentum happening. People recognise that this is a specialty in its own rights. We've got trauma services such as TOPS and everything starting to emerge. Our unit that we have at the Austin, where I also work, is predominantly elderly patients. More than 70% are over the age of 65. Drives my poor registrars crazy sometimes, but I love going over there and doing a ward round of only 15 people, not 60. But so that it is starting to, and people will see those benefits. But as Maya said too, I think we need to collect the data and show our executive that it improves the care of older patients and improves, their outcomes.
There's a question about the role of decentralised care. So we're at the Royal Melbourne, but 25% of patients, I think, were mentioned to have come from rural and regional areas. What role does the trauma service here have to foster care within people's own communities? And then I guess looking at that multidisciplinary care, that specialised nursing care, occupational therapy and physiotherapy, how do we best have that model replicated closer to people's home?
Yeah, I think that's a challenging one, and there is certain injuries and I suppose specific allied health restrictions that we have here that might not necessarily be present in other services as well. So we do have some collaboration, especially probably with our bigger regional services, where we often send our patients back to for acute transfers in terms of managing these cases that we see relatively frequently, but they may not. But I think that that's definitely something that we can improve on from an allied health point of view as well.
Yeah. What I'd say is that this can be advantages to people staying closer to home, but I think any shift away from the centralised trauma model has got to come with a really robust registry. And, when you look at the geriatrics model, they've got validated standards of care, they've got a hip fracture registry, so if one service is underperforming, that's identified, things can be changed. And if there's, anything you're doing with older adults, there's always got to be thinking, are we being ageist? Because if you don't, then, it just happens automatically. And so if we did move towards, patients who didn't need surgical care, perhaps staying in their own facilities, you've then got to be looking at things like mortality, complications, functional outcomes. You've got to have process standards, so you're not waiting till, lag outcomes, and education and, networks where people can learn from each other.
Yeah, go ahead.
All familiar with the Victorian Trauma Registry, the Outcomes Registry. So, and that does collect data as long as the patients meet the criteria as a major trauma. So that won't be all of our older folk, but it will be a proportion of them. So that, we're collecting some of it, but like you said, we need to collect it and see how we go. And that is across the board, and they can see how many patients are getting their care, their definitive care in a non-major trauma service as well.
Yes, my thought is to add to that, yes, I agree with all that. Our role as the major trauma service is to develop this model of care, which will take half a decade at least, maybe a bit more. But I think it will be a model of care that can be very easily rolled out to decent-sized hospitals in the country. And we will be able to get a level of care for these elderly trauma patients in Bendigo, Ballarat, Warrnambool that will be equivalent because they usually don't need what a trauma service was set up to do, which is, you know, high-end surgery and interventional radiological procedures to stop exsanguination. That ain't the bulk of the work.
There's some questions, specific questions around CT scanning, and I guess one of them is, what is the utility of non-contrast pan scan in the elderly? Often I wish that my patients at triage had popped through the scanner and then I'd know what to do with them, but what are your thoughts on that?
Where do you want to start? I've got to let the others talk a bit. Let's start with the geriatricians first.
So sorry, so this is about... Can you just repeat?
Yeah, so I guess it's really looking at the role of the non-contrast pan scan screening for injury in the elderly patient, and a second question around the role of guidelines to help support decision making for CT scanning for these patients.
Yeah, so there has been some work going around. I participated in a survey earlier in the year where we're identifying, what are the factors that could improve our identification of injuries for the older person presenting with trauma, and certainly the older person might not present in the same way. So do we need a different set of criteria for who receives a pan scan in the older person? I think I'm still unsure of the answer of that, but certainly we do detect a lot more occult injuries that we weren't expecting on our history taking examination, and we're very lucky to be here at a major trauma centre where most of the patients we're seeing certainly have had that done. I'd be keen for...
I think we might be asking the wrong question, and this is where I've learnt a lot about what I didn't know. When I'm out in the community, I need access to a CT scanner. And so the question isn't should we do the test, but where can we do the test, and in what time frame does the test need to be done? And those are the much harder questions to answer. When I'm an emergency physician in an emergency department like the Royal Melbourne, if I'm not sure, it's very easy to answer that question. I just order a CT scan, and whether I do it with or without contrast is kind of not the point. The question is, when I'm not sure, am I going to move someone a really long way to answer that question? Especially if they're delirious and they need to be sedated to achieve it. And especially when I'm moving them a long way from all the things that they need if there's something there. So the question isn't, is the CT scan the right thing to do? Because I think oftentimes that's not hard. Oftentimes we're very aware that we would get more information from that. The question is, can I get it where I am? And what's the risk in trying to move someone to achieve it? And I've learnt a lot recently about the imaging available in the community. It is very easy to get an ultrasound in a residential aged care facility. It just takes a couple of days. So I have to answer the question, how long can I wait? Not do I want the test? Same with an X-ray. I can diagnose a limb injury very easily. It just takes a couple of days, and I can put a splint on while I'm waiting for that. The CT scan is the hard one, but we have progressed at the Royal Melbourne to having a really amazing transit lounge that is becoming a great place where we can bring a patient in an ambulance with their loved one that helps prevent delirium on a day that suits them with a booked time, and I can get a non-contrast CT scan, I can get a head scan, I can get a net scan, and then I can send them home again while I figure out what I'm going to do with that. Now that's game changing. If we all had that sort of access, then maybe we might be able to advance the kind of care that we're delivering, and we might be able to make the timing of the CT scan suit the patient rather than us. And I think that that's something that we really need to move towards. Now, I have no idea what that looks like in the future, but I do know it's possible. I just don't know who benefits from it most.
I would benefit working in an overcrowded emergency department, so I'm supportive, Maya.
And I think too, we know that the earlier we diagnose the problems, we can then get on and treat them. So don't delay. Radiation doesn't kill old people, we'll put that one out there, and contrast doesn't either. If you go full on and give them too much, or go backwards and forwards and do more CTs with contrast, yes, that will. The other thing, though, I think it comes back, will this test change the management for this patient, whether they're in the community or in the hospital or wherever? And if the answer is yes, you should do the test. Whether it is for prognostication or giving the family information, yes, mum's got a large subdural, we're not going to operate on it, but this is what you can expect to see happen. Versus we might need to withhold the rivaroxaban because the spleen doesn't look very happy. So if it's going to change management, it should be no different just because that person's 95. It's just that the reasons for it may not change management in the older folk. You may still go down a certain pathway.
We're out of time, so I'm going to go back to David.
Okay, thanks, Emma, and thanks to our panel for their fantastic contributions and that lively discussion. If we could just give them for our audience a bit of a round of applause. And we will be giving them a little gift of some chocolate, and I think it's with licorice, so we can keep them regular. Yeah. And so we're a very bowel-focused trauma service. For audience members, if you could give us some feedback, what you liked, what you didn't like, was the AV okay? It was just give us some feedback, because we have been acting on this in the past. We know that you like the cases that we put through them. There's the link to give us that feedback. And just to let you know that the next Trauma Grand Round is being held by the Alfred, but I don't think we've got a topic or date yet next, because it's going to be next year, so on the other side of Christmas. So thank you everybody for coming, and our final thank you is for Kelly Gunn for organising all of this and keeping us all in line in a Sergeant Majorly way. Complete with the shouting, so thanks, Kelly. You can have some chocolate with licorice as well if you like. So thanks everybody, and have a good rest of your evening. Okay, thank you.